Content warning. This episode contains mentions of suicide and bullying. Please see the show notes for resources to seek help. This is On Diversity, a podcast series by the Institute of Policy Studies, Singapore. This is the 4th season and I'm your host, Liang Kaixin, Associate Director of IPS and also a former journalist. Today's episode is on the destigmatizing of HIV and AIDS. We have Dr Rayner Tan, who is an assistant professor at the Swee Hock School of Public Health. His research interests revolve broadly about the social determinants of health, community engagement, implementation science, and health equity of vulnerable communities. We also have Terry Lim, Associate Director of Outreach Education and Testing at Action for AIDS, leading its heterosexual outreach work. Welcome to the podcast today.
Thanks for having us.
Yeah, Singapore's social acceptance of HIV still lags behind scientific progress and have not moved beyond narratives of fear and prejudice from the early years of global epidemic. This is what Rayner wrote in one of your op-ed. So just to start things off then, what are some stigma that is still around the virus and what are some common misconceptions that are contributing to this stigma? And how can education and awareness campaigns help dispel them? Maybe we start with Terry first.
Lack of education, lack of awareness and knowledge create a lot of fear and a lot of myth. So a lot of people, not that they do not want to help or what, they just don't understand the whole virus and everything, then they have that fear. So they will not help, and then that create a lot of misconception.
Yeah, thanks, Terry. And I think one thing that I will add is that where did this fear come from? And I think early on, there was a lot of panic, 1980s and all that, because we didn't know. If you imagine COVID, when it first came out, everyone was like, not sure how it's transmitted, how do we protect ourselves? We poured a lot of resources into it and then figured that out. I think similarly for HIV, back in the 1980s, people were fearful, didn't know what to do. But what was coming out then were like all these narratives about these different groups that were vulnerable. Since then, we've created laws, we've created policies, but also because of the stigma, I think we don't talk about it much and we actually don't bring it up a lot in terms of our policy discussions. I guess it's been stagnant from there.
So it's very interesting because I was just telling my friend that I'm doing this topic, right? And my friend was like, oh, so does your guest have HIV and will this spread to you by saliva? And I was so horrified. I mean, what's going on?
It's lack of knowledge. I can actually share so many stories on that. We receive a lot of call for help and information and all this. Example, there's an owner that called us. I locked my maid in the storeroom. She just tested positive. So we're like, why do you need to lock your maid in the storeroom? Another example, you think you've been honest. There's an employee. She thought that it's good that I share with my employer about my status. So we share with the HR. And you know how unprofessional it is? The whole company gets to know. They don't want him to share the same pantry, cannot use certain toilet. Eventually, they ask the HR to choose either him or us. Either you ask him to leave or we leave. So at the end of the day, you see the common thing is knowledge. I don't think they actually have anything against him, but they were so worried that they will get HIV from like sharing food, pantry, using toilets, this and that. So it's still like that.
Yeah, and I think for HIV, one thing is that when we think about it, it actually brings up this image of something that's shameful or something that has a lot of stigma around it. So because we don't talk about it, things like what Terry just mentioned in terms of knowledge and how it's transmitted, we don't actually have that kind of conversations. So if we don't really understand how it's transmitted, I think it's very easy for misconceptions to take hold as well.
I add on to that. I always ask this question, sexual health education, whose job is it? Is it Rayner, Terry, to educate the whole population or what? I think sexual health education starts from home. You need a village to really bring down HIV or increase the knowledge. Start with parents. Parents should start talking with the kids about sexual health education. School. Is our school doing enough? Are they talking about PEP, PrEP, testing, and even touching on topic like discrimination? And are we doing enough? AFA, are we doing enough? Health Promotion Board. So you need a village to really come together, and the more we talk, the more we understand, and the less fear we have. But in Singapore, sadly, is that nobody wants to talk. When you ask your parents, say, go ask your teacher. I'm not sure how equipped the teacher talking about sexual health to kids in Singapore. So it's still a harsh thing here and there. I don't know whose job is it.
So Terry, you mentioned PEP and PrEP.
Yeah.
What's that?
I think it's 10 years ago when we started off, like what you say, scientific research and medication have advanced way ahead. When we do show in a club, when I mention PEP, my community, heterosexual, none of them know. I told them within 72 hours, you can take this pill, it will prevent you from getting HIV. They are shocked. They say, what is secret pill? Like, how come we don't know about this? And then now we're talking about PrEP. But there's some improvement, 10 years and now we do a lot of outreach, 200 over shows in every clubs. And like all those people, like my generation, 70s, 80s, even 90s, we went to school, we went through whole school system without sexual health education. It's just like your handphone. You need to upgrade. You need to upgrade knowledge. Whose job is it to upgrade their sexual health knowledge? They don't know. They still think that HIV is a death sentence. Oh, it's a death sentence. Oh, no, I don't want to test. Once I test, there's no help, there's no medication. During the 80s, I see my friend just go. So we have to go down and tell them, look, the only way is take your test, medication, you can live as normal. When I say you equal you to my community, they're like, you equal you. So the knowledge is not there at all, and I don't understand why.
Okay. So, Rayner, maybe you can elaborate more, like what is PrEP then?
Yeah, actually I agree with Terry. You need to update your software, your OS, like every now and then, right? Because especially for HIV, things like PrEP or pre-exposure prophylaxis, PEP, post-exposure prophylaxis, or even things like U equals U, undetectable equals untransmittable. All these are prevention strategies. And these are all in the last 30 years of HIV science. We've come so far to develop all these things, right? I think for PrEP, or pre-exposure prophylaxis, this is where you can take a pill on a daily basis, or they also call the other type on-demand PrEP. So you can actually take it when you know you're about to have maybe activity that might put you at risk for HIV. And it actually effectively reduces HIV by up to 99% if you take it as prescribed, especially for daily PrEP. It's actually part of Singapore's guidelines also for prescribing PrEP. So if you belong to maybe certain groups that are vulnerable to HIV, or maybe your partner is living with HIV, these are some things you can also consider to prevent HIV transmission.
How do we not know this?
I think MSM community, the HIV knowledge are much higher. They have all the social network or community. You call
MSM
it community.
as in
gay community.
Yeah, okay.
So you have a community and they look out for each other. They so-called update each other on what is the latest medication. But for hetero, no. We don't have a community or we don't have a place where you go there and you have all your sexual health knowledge. Zero. You have to go out. And it's very hard to reach out to 40-year-old and above, blue collar. That's one of the main issues. They are all the late presenter. You have to go down to the ground, in person, coffee shop, Thai, in the club, to meet all these people and upgrade their knowledge. If you expect them to Google what is PEP, they don't even know there's such word PEP, PrEP, and how you expect them to Google. So a lot of work. You have to really get down to the ground, go down one at a time, and then slowly, eventually, more people will get to know, hopefully.
Terry, you mentioned Thai and clubs. What do you do there?
You see, the demographic, people who get HIV, we get the information from medical social workers and all this. Late presenter, they are mainly 40-year-old and above, Chinese-speaking, blue-collar. How to reach out to them? In one shot, you can reach out to 2,000-3,000 such demographic, such audience in Thai. So we park our van, we have a mobile van. 10 years ago, when we approached them, actually, all our program, where we approach anyone, we're being chased away everywhere. But don't give up. You just have to push on and push on. Now we have the van parked beside Thai. We have ambassador up in the stage telling people, hey, take a test. Because you take a test, you can prolong your life. You can live as normal as possible. We have 60, 70 people queuing up, uncles, auntie queuing up to take tests. Slight improvement. Thai and coffee shop as well. Coffee shop where have a lot of uncles sitting down, drinking. So we share all this information with them. It's like a new information to them, like they never heard of all this information. Very intensive manpower, but you still have to do it that way, old school way.
Okay. So Rayner, then what are some ways to actually help to improve this kind of education and awareness campaigns?
I guess Terry's doing a really great job together with the AFA folks because we've got community groups leading the way in terms of educating who we think are vulnerable, right? And I think one thing I would add also is that from the 1980s, we think about, okay, these are all the risk groups, maybe sex workers or gay, bisexual men, people who inject drugs. But actually, honestly, we've seen cases like, for example, spouses of men who are maybe sexual partners of some of these populations. So if you think about it, anyone could actually be vulnerable. And what I would say is that as long as you're exposed to certain risks, that makes you vulnerable to HIV. And what we don't talk about maybe enough is how do we know whether you're at risk, the sexual health empowerment aspect of things. So those are some of the things that I guess might be strategies for how to really address HIV. If we can start from, let's say, like Terry mentioned, families or even schools to think about HIV just not as a disease or a virus that affects only certain people. Then we can actually very holistically say that, okay, I'm putting myself maybe in this situation. There are certain risks involved, including like HIV, sexually transmitted infections. Although the risk might be lower for certain communities that I belong, but it's always there. When you have sex and let's say if it's not protected in that sense, I don't know, sometimes think about statistics, right? You say, okay, my chance is like 0.1% only. But actually, your chance, I like to put it, is yes or no, right? It's like 50-50, right? Because you never know, not everyone falls within those statistics all the time. I would say that empowerment and being able to understand what I'm doing and what the risks involved is something that we don't talk about enough.
You know, when you say that anyone could contract it, right? This leads to my second question also, that we know the fear of career repercussions prevents some individuals from getting tested and disclosing their HIV status. How can workplaces and government policies create environment that support individuals who are living with HIV and also encourage open conversations about their health without fear of discrimination?
I just shared that story about employee sharing. I think in Singapore, we are still not ready and to share your status openly with anyone. I think the repercussion is really great. When you have any other chronic illness, you share with your loved ones and you have the full support of everyone. With HIV, it's totally different. When you share, that's the end. People will run away from you. I have a few stories that I can share with. She's a uni student, one boyfriend, HIV positive, and then she shared with her best friend. All discriminate her, shame her, and then she left. She went UK at the age of 22. Somehow the information leaked. People shame her on social media and everywhere. She took her life at the age of 23. So HIV didn't kill her. What kills her? The pressure from people, the discrimination, the stigmatizing. And so it's still very scary. It's still like that. And I just shared a story with you before we start this program. We received a call from a social worker, a local polytechnic school counselor. So she called AFA. We have a boy, HIV positive. Can you come down and brief us? Sure. No, we can't. I thought I'm going to brief her about HIV and the policy and what them not to fear and this. She said, can I bring you to the theater? So I said, okay, we need to go to the theater. Okay. So we went in the theater, stepped in, there are 40 other personnel in the theater. I said, okay, full stop here. You mean all these 40 people know that this boy has HIV? Say, yeah, they should know. I said, do you know that you're not supposed to share this status? It's confidential. They'll sue you. And can you imagine all these 40 people, HOD, educator, the question they ask, we should know, what if we get HIV from him? Can he go swim in the pool? No, you use the toilet and everything. It's very high risk to everybody. That I'm not talking about 20 years, it's like 5-6 years ago only. So our educator is at this level. So we really need to, a lot of area to work on to really improve on that. And then, is this discrimination? So a lot of work to do.
Rayner, how about you? What are some workplace and government policies that can help to support the people with HIV?
Okay, I mean, I've been waiting to maybe think about whether I should talk about this, but I think in the spirit of things, I'll draw from maybe my own experiences also. I'm also a person living HIV, and these are some things that I face when thinking about employment. And there are some things that, I mean, I hate to talk about research, but research being my field of my industry, actually, we did a recent study as well on people's experiences of HIV discrimination in terms of employment. And I think our collective experience really has been, there's this fear of not just anticipated discrimination that Terry talks about, but there's also a fear of the unknown, right? Because once the information is out there, you actually don't know what people are going to do with it. And you don't know what's going to happen to you even beyond this job.
Rayner, I think this is the first time I know about this. Are you sure you want to talk about it?
I mean, I've done it in public talks
Okay.
and also with corporates. We have a few different corporates. So I think it's quite okay.
Sure.
You can, if you see me, I think you don't really think about that. And I've been living it for maybe about 10 years already. That's something that comes up when you apply for jobs, right? You think about, if they ask you, there are some jobs that might be discriminatory. They might ask you specifically whether you have HIV or not. And actually that is a big discriminatory kind of point, right? Because you might ask yourself, is this related to the job that I'm going to work at? Maybe for certain jobs where there's exposure, they call it exposure-prone job, maybe in medical care, this might be something that's relevant. But I think to have that when it's not associated with the job might be quite discriminatory practice. Like I think what our research actually proposes is that if you do have a framework for anti-discrimination around things like HIV or even other things that people might think about that stigmatize, for example, even mental health, right? You won't really have a fear of disclosing these things, especially if they're relevant, because you know what's the limits of what people can use that data for, and you know what the protections there are against it.
Okay. We know that people can go to anonymous testing clinics, right?
Yep.
Yeah, but if they actually undergo HIV testing, the doctors or the laboratory staff, they are required to inform the ministry, right? Within, I see, 72 hours of diagnosis. My question is really like, is there a need to continue to have the HIV registry, especially after having the data leak previously in 2019?
Maybe before we touch on the data leak, you mentioned testing.
Sure.
Actually, before testing, there are at least 7 barriers we need to remove before testing. Why people don't come out to test? They still don't trust the system. People still coming up to me that when I encourage them to test, when I take tests, the police will catch me. They'll inform my whole employer, my family. They will lock me up. And so all this have to be removed. They have to make them feel safe to take a test. It's okay to take a test, and then next thing say, I take a test for what? I will die anyway. So the knowledge is not there. So we assured them that medication is way ahead, is available now. You live as long as. So we have to remove so many myths and fear and everything just for them to take the test. Like I say, why we have an anonymous test center? Because with name, they feel that they are not protected. They don't trust the system. People might get to know about my status, this and that. So you ask me, should we have names? Like I run program. I don't need names, whether Rayner or Terry or who is positive to run my program. I don't need a name. I need other information like what Rayner will tell me, 40% of, this group, this age, this demographic, this education and this. I need this kind of information. Names don't really help me to run my program at all. Oh, this guy tested positive, his name is Rayner. For what? So I need figures like the behavior, traveling to neighboring country, they get infected in neighboring country, they travel. So I have to cater my program, okay, people travel out and have sex. How are we going to engage them and tell them? I think AFA, we feel that no, we don't require names to run our program. Clinically, I'm not sure whether you require a name there to improve the...
Yeah, I guess being from public health, I think having a registry makes sense. What is the shape and form of this registry, right? Like Terry mentioned, do we really need names, or is this more maybe de-identified kind of registry so that on one hand, we know how to track like the number of maybe infections in a year. We know who might be more vulnerable to it because we can analyze that. But at the same time, what the leak actually taught us is that this is something that's very highly stigmatized. And right after the leak happened, we hear reports of people being super distressed and being what I hear is that people were also suicidal following that, because something that you've kept secret for a really long time and not wanting people to know is suddenly out there in the open. And the worst thing is that you don't know where it is and who's going to use it in the future. So it's like living with a sword over your head, right? In this lifetime, for wherever you go, this sword might fall at any time and you don't know it. So I think that really is the fear that's associated with something like that.
But I also know that, if I'm not wrong, There's also a lot of associated policies or maybe regulations that HIV persons will have to live with, right? Were there any restrictions to traveling?
Previously, many years back, there's a lot of people are working behind the scene to help improve the situation, especially travel ban. Now we are allowed to travel in, out of Singapore. Some are allowed to even work in Singapore. I should say there's improvement, baby improvement, even classified or recognized HIV as a chronic illness and they can tap into Medisave, Medishield. Previously, they can't. There's a lot of people working behind the scene, helping to push, to improve the policy and covers everybody. Have you mentioned campaign? Not yet?
Yeah, please go ahead.
So we have a campaign with ministry and doctors and the national radio station. So we run the campaign across the country. We went to a place and then we do sexual health talk to communities, to this. One lady picked up the mic and tell the doctor, say that they don't deserve help. Why are we spending money to help all these people? They deserve to die. The doctor shocked, panicked, the DJ panicked, everybody. So they were like, next question. Or I said, no, we have to address this. So I took up the mic. I said, when you're sick, you visit the doctor. The doctor's job is to diagnose, analyze everything, and then to cure you. If we come to a day where the doctor have to judge who to save, who not to save, or you are a smoker, or you don't deserve treatment, or you are so this and that, you are a drinker, you are a criminal, we shouldn't save you. I think the day we started to do this, I don't know what world would that be. So I said, if you're sick, you see, the doctor's job is to save you, full stop. We don't judge it. Oh, why you're sick? You're so fat. You don't deserve treatment. I don't. Of course, she's very angry. She went to the backstage and continued her fight with me. I say what I needed to say. I just needed to say that. I say, no, we don't judge people. Whoever's sick, treatment, full stop.
Yeah, and I wanted to add to the point on some of these policies, right? I think, if I remember correctly, until 2015, people living with HIV weren't even allowed to enter Singapore. There was a short-term travel ban. But I think after 2015, you are allowed to get the social visit pass, enter Singapore as a tourist or a visitor. But we still have bans on work passes over here. And I guess this is in contrast to a lot of places where I've managed to get work permits, the US or even China. Places like that have moved past that because I think there's a recognition that HIV is actually not infectious if you are on treatment. Like, you can't transmit HIV through sex if you are on treatment and you're virally suppressed. And that's what treatment does. Basically, viral suppression means that when they draw your blood, they can't find the virus because the treatment prevents it from replicating. In that sense, it makes no sense to actually ban people who are not infectious. I think this is also, it ties into another point, which is one of the other policies that are quite relevant. And I believe it came out in a newspaper where there was this criminal case of someone not disclosing the risk of transmission for HIV. So some of these things, at least in the research that we do and the conversations that I have with community groups, it's like, now that HIV science has progressed so far, and that's why I wrote that in that op-ed, right? How do you communicate to someone that you've got no risk of transmission? That's a bit weird, right? Because the law requires you to communicate the risk of transmission to someone else. But if there is no risk, do I communicate to you that, hey, actually there's no risk of you getting HIV from me? In the absence of that risk, it's a bit funny. That's something that is also quite relevant today.
But Rayner, I think not many people know about this no risk of transmission. Can you explain it a bit more? I think you mentioned about U equals to U, right? I don't think a lot of people know about this.
Actually, to be very fair, this is like new, I wouldn't say it's new science. We've actually known this from early 2000s. Like HIV medication, the highly active antiretroviral therapy, which is the medication that people take, the antiretroviral therapy, it started coming in 1996, I believe. Actually, from there on, all these like clinical trials, they started to realize that, hey, actually those people who take this medication and have suppressed the virus, their partners didn't really get HIV, even though they were reporting unprotected sex. This led to, in 2008, there was a Swiss statement, which some researchers at a conference when actually we can claim that when you are virally suppressed, you don't transmit HIV. But then a lot of people at that time were like, are you sure? That there wasn't enough evidence then. But since 2013, there was a big study, 2016, another couple of big studies. There is even stronger evidence to show that. I think it was like something like 126,000 sex acts that were not protected. There was 0 linked transmissions of HIV. When I say linked transmissions, it means that they actually did some genetic analysis. Even if there was a HIV transmission reported, they did genetic analysis. They realized that it's actually not from the partner that had a virally suppressed HIV. So actually this year in July, WHO, the World Health Organization, released new guidelines to actually say that when you are undetectable, means that you cannot detect the HIV in your blood. In clinical terms, basically they say that when you have less than 200 copies of the virus per ml of blood, it means that you cannot transmit through sex. And previously, everyone was very afraid of using the word cannot transmit, right? This kind of wording is very definitive, right? In the last 5 years, we were like, okay, we kind of believe you, but we will use things like virtually 0, effectively 0.
0.0001%.
Yeah, if you read all the newspaper reports, it's like very low chance. Okay. But then this year, WHO there is no risk. So they also encourage a lot of people to say there is no risk of transmission in these kinds of situations. I must add that, but to establish these situations that you have undetectable viral load, that these kinds of things are happening assumes that you're taking your medication as prescribed, and medication is effective. And these are things that you need to talk to your partner about. The communication, then it becomes very important.
But the law in Singapore is still in place, right? That if you are HIV positive, you must inform whoever you are having sex with that you are HIV positive, like, right? Yeah. If not, you will be committing a crime, like, in a way.
Actually,
yes.
There's one misconception there. The wording of the law is you must inform your sexual partner of the risk of transmission. So there have been legal cases where they inform the partner, say, okay, on my dating app profile, I put that I'm HIV positive. But then the legal argument was that, but you did not inform the partner of the risk of transmission. You cannot just tell them that you're HIV positive. So that person got
splitting their hairs.
Yeah, but that's the legal interpretation of it now. And I think maybe it's just the way that the Infectious Diseases Act was worded back then. And when I say back then, this was like a 1990s kind of document, right? And I don't think it has been amended since then. I think they increased the penalties by 5 times. Yeah, that's the only amendment.
Is that supposed to be a good thing? This leads to my next question also about campaigns, right? Are there any successful international examples of campaigns or initiatives that have effectively reduced HIV-related stigma in other countries, and then Singapore can learn from it?
Oh, definitely. There's so many. I have to travel overseas before the Google Times and everything. You have to travel overseas and to see all this campaign. And I saw one hugging HIV positive person. It's just a very simple image, video, hugging, and the tag was like, you will not get HIV from hugging. So simple and so strong. And then another one is touching the blood of HIV. There's a drop of blood that you touch it and then you will not get HIV. It's so simple. And you understand, and then you remove a lot of fear. But can Singapore do that? Our campaign. We do campaign, but the impact is not so strong. It's more like education here and there. And then AFA, we did try, even when Orchard Road, will you give me a hug if I'm HIV positive? In a very small way, but just in Singapore, whatever, especially campaign or anything you do regarding HIV and everything, it won't be shared a lot. It will be just 1-2 days, just die off, unless it's a scandal or something. Otherwise, nobody want to talk about it. HIV? No, don't talk about it. Sex? No, don't talk about it. The lesser we talk about it, no one will understand, no one will know. So we talk about campaign. I hope we can see bigger, more impactful campaign, and then people talking openly, discussing openly about sexual health educations and all these things.
But is it because of some kind of social norms, a perception that people who have HIV often have sexual partners outside their monogamous relationships? So that is why people tend not to talk about it? Would that be the case, Rayner?
Yeah, I think so. I think there's Terry talking about that particular event where someone came on stage and then was like saying people, they deserve it and all that. So there's a narrative of blame, and maybe I'll just share about my own experience as well,
sure.
Right? The reason why, actually, I had a partner, and this partner, I was always very paranoid about HIV. But then with this partner, after dating for 2 weeks, I just thought, okay, maybe it's like safe to assume that you feel safe with this person. But even after sex, it was like, okay, I'm freaking out a little bit. So I went to the doctor and I wanted to find out more about post-exposure prophylaxis. But actually at the doctor, I was still like 21 and I was a uni student. And when I went there, because I didn't know the status of my partner, I think clinical guidelines at that time were like, okay, it's up to you whether you wanted to take it or not. But for me also, the up to me wasn't available because I just didn't have money to afford post-exposure prophylaxis. I wasn't able to access it at the time. And can you imagine if I were to ask my mom or my dad for money for post-exposure prophylaxis, what their reaction would be like because of the prevailing stigma? So it was difficult for me to reach out to resources at that point in time. That time I was also very afraid of HIV myself. I knew AFA existed, but I was also afraid of reaching out because I was the target market of people who live with stigma. But because of that, like the medication was literally in front of me in the clinic. I couldn't take it. And that's when
How expensive it was?
I think in private clinics, the whole course takes about a month plus actually. And one bottle could be about like $600 to $800.
Oh, okay. That's quite expensive for a student.
Oh, yeah. When no money at the time, right?
Yeah.
You know, the whole blame narrative, I think it came from maybe that whole time where stigma came about around HIV. So I think that still exists today and it impacts people who are trying to access services.
And this is definitely linked to testing, right? Because if you don't test, you wouldn't know what to do, right?
Yep.
Yeah, I would say that the anonymous testing service was where I finally managed to get tested immediately after that. Because for me, luckily, I had symptoms, right? And then the acute symptoms, which appears for some people, like fever that won't go away for 2 weeks, that I knew at that point, I was like, I'm quite sure this is it. So because of anonymous testing, I was able to test and not be linked to a registry. And actually, not being linked to that registry meant that my data was not leaked because I only joined the registry like after a certain point in time. And I think these things like anonymous testing are all really important still to reach out to people who are afraid of getting linked or getting identified with HIV.
I think we touched on quite a lot of topics about this. I think we talk about workplace and government policies and...
Oh, the workplace, the discrimination law. AFA wrote in to ask them to include HIV.
Oh, for the Anti-Discrimination Act, right? And what happened?
No answer yet. It's not that. You just have to wait. But at least we try.
Okay.
We want HIV to be in the discrimination law there. So we try and then we see.
Yeah, and I think they said they will review it every 5 years or something like that, right? So, yeah, I guess with a new law, with some of the protected characteristics, we'll see where things go. I think HIV definitely is one of the areas where people do face discrimination and it's quite real. And if I want to recall, I think there was like a couple of years ago, there was a campaign for employers to sign on to pledge against HIV discrimination. This is one of those things that it was pledged, but then it has disappeared into history, right? But then I want to go back and see, no, actually, there were quite a lot of hospitals and employers who signed on to this pledge. And I think there is a recognition that there is discrimination. There's a recognition by a lot of employers that they shouldn't discriminate. If we leverage that, actually, it's something that makes sense that should be included in some of the anti-discrimination kind of legislation.
So in terms of anti-discrimination, right? I mean, usually people will point fingers at the media, but do you think there's anything that can be done? Like how they can contribute to changing public perceptions?
Let me think. I think we cover a few things around education. I think, for example, UN AIDS, which is the UN Declaration on HIV and AIDS, I think that's a full name, but they have terminology guidelines. For example, we don't use HIV/AIDS. We say HIV or AIDS, mostly because AIDS is not HIV. AIDS is something that's quite rare nowadays because AIDS is when it's called like a acquired immunodeficiency syndrome, which is actually what you get when you're at late stage of HIV infection. But the good thing is that because we assume that most people get tested relatively early, they don't get to that point. So they actually don't get AIDS. But if you leave HIV untreated, AIDS is one of the outcomes of not treating it. So stuff like that, if you read through the terminology guidelines, which is very comprehensive, I won't go through in detail here, but if you're interested to find out, especially for folks in the media, how to write something that's not stigmatizing or not to perpetuate these kinds of myths around HIV, terminology is a great way to start.
What about the healthcare professionals then? In clinical settings and within communities, are there anything that they can contribute to support HIV patients also?
I can think of actually I know that there are some educational programs that are being conducted by our national HIV program. sensitivity programs also around HIV. I would say that research is showing that even some healthcare professionals might feel hesitant to use the kind of definitive language around you equals to you, around there's no risk. Because, and you can think about it, actually, HIV is a very complex illness or disease or virus to actually control, because when you want to communicate this kind of like scientific things that there is no risk, actually there are many things stopping you, like my view on sex, my view on so-called like a certain lifestyles. If I say this thing that is scientific, is it encouraging certain kinds of like narratives or behavior? And actually these kind of things come from maybe, like stigma associated with sex, or stigma associated with like maybe certain key populations that are affected by HIV. Maybe if I know that you are doing sex work, or if I know that you are gay, for example, maybe I better not tell you all these things. Maybe I better leave the science to myself, because if I tell you maybe you're going to have more unprotected sex with people, and unprotected sex is bad, that kind of thing. These are all things that make it a bit more complex. So there are actually some interventions to maybe think about how healthcare professionals can better communicate things, or how you can actually destigmatize HIV, not just at the population level, but we can start with like hospitals and healthcare institutions also.
I think the word is normalize. Normalize testing, normalize it's chronic illness. You don't look beyond that. Just normalize it. It's a chronic illness, but it's easy to say.
But it's difficult to do, right?
Yeah, mindset and our Asian thinking and belief and everything. It's not easy to change, even religious group as well. There's a lot of push and here and there. But at the end of the day, I feel that it's still sexual health education that everyone needs, especially the youngsters now. They have access to all kinds of social media. If you give a small kids, now kids are having sex much earlier, 21, eh? You mentioned
I think we did one study at the mean age was like 18. Yeah. Like people start as young as 13, right?
Yeah, now people start young as 13, 12 with their, as long as they have a smartphone, they are at risk. Teenagers are already sexually active. So our sexual health education must quickly catch up. A bit slow now. Teenagers are really way ahead with social media, with hookups, and it's much more easier to have sex now than way back. So our sexual education is still lacking way behind.
Yeah, I want to touch on that point. But the good thing is that majority of people start at an age where maybe they have more information, they have more empowerment sexually, because the fact is that people start way earlier than that. And making sure that we have the right kind of school-based interventions to target these people who might be in the minority. But then if we don't do that, then these are the people who will maybe face certain kind of risks or consequences that we don't want them to actually face. So I think acknowledging that and actually making sure that our sexual health education is comprehensive to not just hide the fact that there's some people starting at this age, but recognize that, discourage that on the basis that maybe there are certain kinds of things that you might not have considered at that age, or you might not have the resources to consider. I think that's something that is more pragmatic and practical as a solution.
Yeah, so Rayner, we saw that you wrote an article about how the use of COVID-19 self-test kits and vending machines could be replicated for HIV testing. Will that be possible one day?
Okay. The article was inspired by COVID. We started to see examples of vending machines for testing kits come up. But who is the expert here? Terry is the expert, because he is the one who is rolling out a HIV self-testing program in Singapore together with AFA.
Are you serious? You mean there's really such a thing now?
Not yet, but very soon we hope so. We started 2017. We went to a conference in Africa, Durban, and then USA, even Thailand has already started rolling out self-testing. Why not Singapore? We came back, we present the studies and everything. 2 years of feasibility studies and everything with a lot of people. Almost going to roll out, then we are hit by the pandemic for 3 years. So 3 years stopped, we didn't do the HIV self-testing. But then that also changed people's mindset about self-testing. You trust people to self-test. So now we actually started trial for almost a year or two. You can buy the self-testing kit in DSC, Action for AIDS. But we hope very soon we'll roll out nationwide. You can buy from vending machine, from 7-Eleven, Cheers, with the full instruction, with numbers, hotline, and all the help that you need are all there. We hope that we can even come up with a video, and then you can just follow the video. You look at the video, do your self-testing, and then Test yourself.
How does it work?
Oral swab. It's very easy.
Are you serious? I was thinking of like drawing blood or something.
No. And at the moment, you can have your result in 20 minutes time with our clinic. You just a drop of blood, or you can do oral. Within 20 minutes, you get a result. You don't have to wait for days for your result. Within 20 minutes, you get your result, and then that's all. That's simple.
So this is a kit that is developed somewhere else, and you're bringing it to Singapore. Can I say that?
Okay, don't want to name the manufacturer, right?
Sure.
But then, so it's actually developed by a medical devices company. It's been rolled out like internationally. If you go to stores in like the US or in many different countries around the world, you find it in like their department stores. So it's actually quite well established.
Wow, okay. This sounds like... why don't we know about this?
Is that people are buying from internet. Why not we legalize it and don't do you buy from internet and then you're not advised by professionals, and do it professionally, legalize it, self-testing, and then you get help, you know where to get help. And
I think one thing that people can be rest assured is that, okay, perhaps it's still going to be quite stigmatizing to, if you want to go 7-Eleven and buy condoms, I will take condoms, I'll take magazine, I'll take chocolate, put a lot of things and hide it there. Similarly, I think this is going to happen. People might be afraid of showing someone else that they're buying it. Like, you can still get it from community groups like AFA. That also opens up room to test out things like home delivery, especially now we've got all those like delivery boxes elsewhere, right? It doesn't have to go into your letterbox where your mom or dad or someone in your family finds out. These are all innovative things that we can test out once that is actually rolled out. When I was working in China, they also did a study that used friend referral. For example, you give someone 5 testing kits, and then you tell them you can give these kits to your friends who you think might need them. And they found it to be very effective. And actually, people want to be very altruistic. People want to help their friends. And so they gave these kits out to their friends, did surveys. So it's very feasible. These are things that open up new possibilities for our HIV prevention once it's allowed here.
This will reach out to the group of people who are so afraid to be seen at the clinic, health professional. They want to do it on their safe premises and everything. Yeah. This group will, eventually we can reach out to them.
Yeah, and one thing I will add is that Singapore, we haven't talked about 95-95-95. UN AIDS has the 95-95-95 goal, which is saying that 95% of people living HIV should be diagnosed with HIV and know their status. Of these people, 95 should have access to medication and taking treatment. And of these people, 95% should be virally suppressed. Actually, Singapore is doing very well for the second and the third 95. We already hit the targets. But our first 95 is the weakest in terms of actually having people get diagnosed. And you can see that as like a result of a stigma, right? Like it's hard to get tested because of all the things that we've discussed today. But you can tell that maybe we will be able to get that last bit of people up to the 95 when we roll out something like that. So I think that's the hopes that all of us have working in this area.
So in conclusion, we really hope that HIV patients can be treated like any other chronic disease patients, right? Like diabetes or high blood pressure, like they are just going to be on medication, but just any other one, right? Any other people. I would like to thank my guests, Dr. Rayner Tan and Terry Lim, for their time today. Thank you all for listening in. See you on the next episode of On Diversity.
Thank you.
Thank you.
On Diversity is a podcast inspired by the Institute of Policy Studies Managing Diversity's research program. We are available on Omni.fm, Apple Podcasts, Google Podcasts, and Spotify. Please follow or subscribe to the On Diversity podcast to get notified when we have a new episode. You can visit our website, ipscommons.sg, for more information.